Assalamu alaikum. I hope you all can hear me.
Yes, Meena,
Yes.
you're audible.
So I'm Minali, the General Counsel Chief of OHCA. Today I will be introducing OHCA and IFMSA. This is basically a collab between the two of them. And then I will be introducing Dr. Sara to all of you. Out of Hospital Cardiac Arrest, Pakistan chapter was founded by Dr. Tahir Shehzad and Dr. Fazeen Fatma in 2019. OHCA is a leading cause of mortality and morbidity around the world, particularly in countries like Pakistan, where there is a lack of awareness and education. OHCA Pakistan chapter, an NGO that is run by medical and non-medical people, is offering awareness and training to the general public about life-saving CPR skills, with the hope that if another person suffers from cardiac arrest in out-of-hospital premises, people who are around the world would at least know how to help this individual optimally based on available resources and settings. Awareness, training, and resource provision are the core of establishing a satisfactory and reliable structure to manage out-of-hospital cardiac arrest. This organization truly believes in teamwork and targets the general public as our audience because this is the only way of forming a sustainable structure. This organization believes it to be our responsibility towards the society to make it better and safer for everyone. Now I'll continue with the intro of IFMSA, the International Federation of Medical Students Association. IFMSA is a non-governmental, non-political, and non-profit organization that presents over 1.3 million medical students from 143 countries worldwide. Its mission is to promote global health, provide medical education, and advocate for the rights of medical students. IFMSA has a local chapter in Pakistan based at Shifa College of Medicine, and we are very excited to have them as a partner for this session. Now I would like to introduce Dr. Sara to all of you. She is an MD Assistant Program Director of Emergency Medicine Residency Program at Bader College of Medicine, Houston, Assistant Medical Director at Ben Taub Hospital Emergency Center, Houston, Texas, United States. Thank you. Now, Dr. Sara, you can continue with the session. Hello.
Okay, got it.
Assalamu alaikum.
Hi. Walaikum salam. How are you guys doing? Good evening, I should say. I keep trying to turn on my video, but it's not turning on for some reason. So I apologize for that. So today we're going to be talking about the approach to the trauma patient. And this is actually meant to be about a 2-hour lecture. So I'm going to try to get through as much of this as possible, but may have to leave some of this to another day because it's broken up into 2 components, basically. The first, we're going to go over some basics around the approach of the trauma patient. And then next, we're going to go through some specific cases, which is meant to be very interactive. I don't have the chat open anymore since I'm sharing my screen, so I can't see it. So if there's questions or things like that pop up, if someone could just monitor the chat and let me know, that would be great. So first, we're going to go through ATLS basics, which is the approach to the trauma patient. Just like we have ACLS when we have medical codes, ATLS is how we approach our trauma patient in a standardized way. We'll go through some procedures, including chest tubes, and then we'll go through some cases that are meant to be really a diversity of different presentations, all the way from starting from a very general approach to a trauma case, all the way to specializing into OB, peds, and geriatric trauma. So first, talking about ABCs, right? ABCs is airway, breathing, circulation. It's probably the most important, one of the most important things we do within ATLS. This goes through, this is a Karachi 2021 Dawn article where they look at the fact that Karachi is no stranger to lots of traffic accidents, interpersonal violence, and other etiologies of trauma. So it's something that in Pakistan, they're very familiar with. And over the 10 months alone in 2021, Karachi had 154 deaths due to road traffic accidents. And so despite the pandemic lockdowns and things like that, what we've seen is that the trauma volumes are going up, and we've seen the same in the States. Our trauma volumes have been higher than even pre-COVID numbers. So trauma evaluation is kind of different than your traditional approach to non-traumatic patients. You know, your traditional approach is you really have the gift of time on your hands. You can do an HPI, you can complete a physical exam, you can get some initial impressions and evaluation from that, you develop a differential diagnosis. At some point, you might get some results back, and you come up with your final diagnosis and treatment plan. Chama is a little different. You have to really assess people very quickly with very limited information, identify threats to life or limb, treat those threats, right? And sometimes you have to use your instinct and what you find very quickly on evaluation, because you may not have a definitive diagnosis, right? And that's okay. Not having a definitive diagnosis should not impede you from doing the appropriate treatment you need to do. And then once you kind of get those things addressed, then you can kind of go and do everything else. So first thing we're going to do when we go through the trauma patient is kind of our stepwise approach. The first thing is a primary survey, which are your airway, breathing, circulation. Then you typically do resuscitation based on what that primary survey shows. After that, you'll go on to a secondary survey, which is a more head to toe kind of detailed exam, looking for any other injuries. After that, you figure out what your definitive management is. And then most times we'll do a tertiary survey. That typically happens in the inpatient setting or prior to discharge from the emergency department if the patient's getting discharged. And it's to make sure that there's no other injuries we missed on the patient. This is a little bit of an algorithm that you can find that was published in one of the European journals of trauma. So first thing you want to do is look at vital functions, look at resuscitation. We'll talk a little bit about FAST, which is listed here as some imaging that you can do at the bedside. You want to determine stable or unstable, right? And if they're unstable, you're doing damage control, whether it's they're bleeding internally, they need to go straight to the operating room, right? Or if they have like an arterial bleed and you need to ligate it really quickly, or if they're not protecting their airway and you need to intubate them, right? So you're going to deal with the unstable things first from your primary survey. And then once the patient is stable, then you're going to go on to your secondary survey and figure out what next steps need to be. So first part is airway, right? So easy way to ask about airway assessment is when the patient comes in, we were thinking of doing it just asking the patient, what's your name, right? And if they're able to kind of respond to you once you ask them a question, their airway is intact. There's nothing kind of blocking their airway. Next thing to think about with airway, we always think about is whether they need intubation, right? So if they're obtunded, they're not able to speak, then those are really obvious times where you're going to intubate them. The other thing we generally teach your residents is typically if their GCS is less than or equal to 8 or their Glasgow Coma Scale, they probably need to be intubated. That means they're probably not protecting their airway. And the way I remember that kind of from a rhyming perspective is GCS less than 8, it's time to intubate, right? On the right, you'll see there's a little bit of a diagram there that goes through the different GCS components for those who maybe haven't seen it or are not as familiar with it. Apart from that, other times you may want to intubate is if there's an obstructed airway, right? Patient's not breathing because of some sort of obstruction. Sometimes they're not able to protect their airway for one reason or another. And there are times where patients will come in and they might be awake, but they're so combative and they're getting in the way of their own care, maybe because they're altered or they're delirious. They have their adrenaline rushing that sometimes we may have to intubate patients just so that and sedate them just so we're able to get the imaging and the scans and the evaluation we need to make sure they don't have any life-threatening injuries. There's a lot of difficulties to consider when you're looking at intubating a trauma patient's airways. This is a really nice mnemonic I like called intubate. So one of the things we sometimes worry about are instability or hemodynamics. And so I always think it's nice to be proactive and think about these things initially instead of being reactive when things are already going downhill. So thinking about their hemodynamics, if this patient is someone who's bleeding out somewhere and is hypotensive, then you're going to be cautious about the type of intubation meds you're going to use on this patient, right? And you're going to make sure it's something that's not going to drop their blood pressure too much. You may also consider using something like a push dose pressor. We use phenylephrine in our emergency department. The thing to think about is neck or C-spine trauma, right? Some of these patients come in and they may have concern for cervical spine injuries. They might be in a C-collar. So when you're intubating them, you may need someone to take off that collar and hold C-spine stability, which we'll talk about in a little bit. Trauma to the face. So if they have trauma to their face, there might be distortion of their anatomy when you're going to intubate, or there might be a lot of blood in the airway from that trauma. If they're unresponsive or low GCS, if they're bleeding, again, that goes kind of along with trauma to the face, or maybe bleeding, trauma internally, where they can have bleeding in the oropharynx, which makes it difficult to visualize the vocal cords to intubate. Apnea is always a big one, because if they stop breathing, then they're not able to ventilate, right? So you're gonna have to do that for them. If you have a burn patient that comes in, sometimes they can have inhalation injuries and thermal burns inside, and lots of soot in the airway, which can make it difficult. And of course, just like anything else in the airway, if they're having any sort of vomiting, or nose bleeding or hemoptysis, you're gonna have maybe some of that encountered in the airway, blocking your view. So it's always good to kind of have your suction ready in those cases. Other things you can do primarily, and this is stuff that sometimes they'll do in the pre-hospital setting when they come in via ambulances, a quick finger sweep just to make sure there's nothing actually in the airway that's obstructing it. And so you can see some images on the right of how they do that, lean the patient to the side and try to make sure there's nothing in the airway that can quickly be taken out. The next two things you might do is something called a chinless and a jaw thrust. And those are really done to open up the airway. And you'll notice, like, the minute you do this thrust, you'll notice the airway right here in red is much more optimally aligned than when the patient's chin is kind of downward, right? So it helps kind of open up that airway. And it's one of the first things we tell the residents to do if the patient is truly not breathing. Next thing to talk about is the oropharyngeal or nasopharyngeal airway. And again, these work the same way. They kind of, they're devices that you can either put in from the nose or through the mouth. The one through the nose is usually more silicone and rubbery. You typically put some jelly on it to help it kind of glide in from the nose. And then the oral airway, again, can go right through the mouth and kind of helps you ventilate the patient with a bag mask prior to intubating. Typically, if a patient is able to tolerate this, though, it's because they're very obtunded. So I would say that if a patient's able to tolerate this, that's great for a temporizing measure, but you should probably be thinking about intubating them. The other thing that is a great adjunct for you to have within your airway maintenance measures for trauma patients is an LMA or laryngeal mask airway. If a patient especially has like a difficult airway, this is something you can use as a temporizing measure to put in to vent and then ventilate the patient with it if you're not able to intubate them. The only thing I would caution you with about this is that this also insufflates the stomach. So you can use it as a temporizing measure, but after a while, you're going to get quite a bit of air into, there's a possibility you could get air into the stomach too with this. And then the last thing we're going to talk about is endotracheal intubation, right? Which is what we typically do when patients need airway management. One thing that you might see happen is cricothyrotomies, which is where if the patient's not able to be intubated, if they have a tracheal injury or some other reason, or a lot of facial trauma where you can't intubate them through the mouth, you might be doing a cric, which usually you'll do with the help of your surgeons and your hospital, whoever else does crics. For us, it's our ER doctors and the trauma surgeons who both are trained in doing crics. But typically you're using a scalpel, you're going to the cricothyroid membrane, you're finding the trachea, you're opening up and you're intubating straight through there. And out of all the things we talked about, really your definitive airway control, where you're really truly have gotten a stable airway for the patient, is either if you're intubating them or if you're doing a cricothyrotomy. Things to think about when you're doing the airway timing: don't delay it, right? I think if you decide the patient needs to have a definitive airway, just go ahead and do it. Make sure you have all your equipment at the bedside. So make sure you have a scope if you think that you're going to need to do a nasopharyngeal intubation. Definitely have suction, right? We talked about blood and emesis and all sorts of things being in the airway. Your blade in case you might need to go to a cricothyrotomy. And if you have video assisted laryngoscopy, it's really nice to have that too. So that you can get kind of a better view. The only thing I caution about against video assistant laryngoscopy is that if for some reason you get any sort of secretions onto that video blade, it's really hard. It's really hard to see. Make sure you have the appropriate medications that you're going to pick. Typically, we have some sort of induction agent that we use. If a patient's unstable, I personally like ketamine because ketamine doesn't drop the blood pressure as much as something like etomidate does. And then you're going to have your paralytic, right? Rocuronium and succinylcholine are typically the two more common ones that we use, but I tend to like rock. It takes a little bit longer to work, but it lasts a little bit longer, but there's a lot less side effects that you have to worry about with rocuronium versus succinylcholine. And then always consider your push dose pressors. If the patient is hypotensive and you anticipate that they might code during the intubation, you can always give them like 100 mics of phenylephrine. And it's something we actually keep in our intubation kits for that reason. You want to monitor the patient. You can put them on a pulse ox, but typically end-tidal CO2 is actually a better monitoring and gives you earlier indication that the patient might not be breathing. By the time that their oxygen levels are going down, it's probably too late. They've not been breathing for a while. So it's nice if you have end-tidal CO2 to be able to use that as an adjunct to monitor their breathing. Make sure you're oxygenating them with passive oxygenation, right? Put some nasal cannula in their nose, BVM them, get reinforcements if you anticipate that it's a difficult airway. And then if you need to keep C-spine precautions, we'll talk about that in the next slide a little bit, because you want to make sure while you're intubating, if there's a concern for neck trauma, that you're not causing further injury as far as that goes. Okay, so C-spine. There's a lot of different rules that you can use to determine if a patient needs C-spine evaluation. One of the ones that I like is the Nexus criteria. And you can see the criteria right on the right-hand side there, but it basically goes through different components, in which case the patient might need C-spine imaging. So if they have a focal neurological deficit, if they have any sort of tenderness along the actual spine, right? If they're altered, meaning they can't even tell you what hurts and what doesn't hurt, right? If they're intoxicated, because then they're not able to give you a good history, right? If they're intoxicated, or if they have a distracting injury present, meaning let's say they have a femur fracture and that is really hurting them. They might not even be able to tell if they have any sort of injury in the neck. And when you're going to intubate, you're actually going to remove the collar and do something that we call inline stabilization, which looks like this, where you get one person on your team to gently squeeze the head between the forearms and hold onto the shoulders. Typically, this person is kind of doing this while they're leaning down at the head of the bed so that they're not in your way as far as the airway is concerned. Using the ABCDs, you can assess the trauma patient pretty quickly to figure out what they kind of need next. And this just kind of goes through that approach. And then this is a video on intubation. So I'm going to play this really quickly because this is actually going to go through kind of the process of intubation and how you do it. Can you guys hear that okay? Were you guys, when I played that, can someone just let me know if you're able to hear that video?
Yes, we can hear.
Hello and welcome to Aidtronics USA. In this video, we will go over the intubation technique with a video tutorial. This video is meant for educational and instructional purposes. Please use caution in your best clinical judgment at all times. Before performing any of the procedures, please make sure all of your equipment is functioning properly. Turn on the video laryngoscope by pressing and holding the power button for a few seconds. Next, take the plastic blade and insert it over the curve of the scope. You will notice a click at the end of the insertion. This click indicates that the blade has been inserted properly. Position the patient in a neutral neck position. Hold the scope in your non-dominant hand and use your other hand to scissor the mouth open from the side. Carefully insert the blade into the patient's mouth. I prefer to do this more laterally, closer to your fingers. As you insert the blade into the mouth, slide the scope more towards a midline position. This will slide the tongue out of the way. Once inserted into the mouth properly, look at the screen to identify anatomy. Here you can see the larynx on my screen. The goal is to have the tip of the blade resting in the vallecula. Once you have a good view of the patient's anatomy on your video screen, you can do two things. Number one is to take a picture, and number two is to make a video with a simple click of a button. If you click the button once on the handle, you will notice a small camera icon showing on the top of the screen. This indicates that the picture has been taken and saved into the memory. If you click and hold the button for a few seconds, you'll notice a red dot appear on the top of the screen and a counter on the bottom of the screen. This indicates that the video is being recorded. You can record the entire intubation process from the beginning. Next, take your endotracheal tube and carefully insert into the patient's mouth. The cuff on the tube can get torn on the teeth. Please insert with caution. Looking at the screen prematurely before positioning your tube into the mouth can result in a poor view. Take a look on your screen now and see the tip of the tube. Use the camera to guide the insertion of the tube through the vocal cords. Once successfully intubated, hold the tube with your dominant hand and remove the laryngoscope carefully.
Okay, so that's a little bit about airway and kind of the procedure for intubating should you have to do that. So that's kind of our A, right? The next thing we're going to go through is B, or breathing. And that's where you're listening for breath sounds bilaterally, right? You're giving supplemental oxygen as needed. You're identifying reasons for supplemental O2, right? Whether that's by inspection, palpation, percussion, or auscultation. And you're adding, and this is, again, another step where you might need to do more procedures, right? If you're listening for breath sounds and you don't hear breath sounds on one side, you're concerned for pneumothorax, maybe that's a needle decompression, right? Or a chest tube that you might have to do. And then lastly, circulation. One, you want to check pulses, make sure that they have good peripheral pulses in all four extremities, right? If there's any sort of bleeding, you want to control that bleeding, either by direct pressure, or if there's a fracture reduction that needs to be done, then that would be why. Thinking about vital signs suggesting shock, especially when the patient is bleeding, tachycardia is probably the first abnormal vital sign you'll see, so something to consider. You also want to look at cutaneous vasoconstriction, which will happen when the body's trying to kind of conserve blood and maintain the blood pressure. Ultimately, they'll get hypotensive, and then lastly, they'll have a narrowed pulse pressure when they've really bled out quite a bit. There's a lot of etiologies for shock in the trauma patients. The most common one we think about is hypovolemic, which we just talked about, right? Is bleeding, whether it's hemorrhagic and you're seeing an open fracture on an extremity where they're bleeding out, or whether it's internal, right? Maybe it's a retroperitoneal bleed of some sort. But there's other types of shock and trauma that you should think about as well, or in general, to be on the safe side. So I just want to mention those briefly. One of them is neurogenic. That's probably the next most common kind you'll see in trauma, right? Where they'll have some sort of spinal injury where they could have shock. Typically, they might have bradycardia in these cases, which is the opposite of what you would think about in most trauma patients. So if you see a patient who's bradycardic with trauma and is hypotensive, you might want to think about like neurogenic shock. The other one you can see is cardiogenic, and typically in medicine, we think about like MIs or heart attacks or arrhythmias or cardiomyopathies, but you also want to think about these things in trauma if they could happen, especially if you have like a syncope fall and you have an elderly person who comes in after a fall and you realize it's because they syncopized because they had an arrhythmia or they have a cardiomyopathy. And the last one you want to think about is obstructive. And so that's one that you can actually see quite a bit in trauma. And so one of the things we think about as examples of that is attention pneumothorax. Other things could be cardiac tamponade, especially if they have a penetrating wound to the chest that's causing them to have bleeding and tamponade physiology. And less likely in trauma, but more so in medical patients, you can also see PE as a cause of obstructive. obstructive shock. So for circulation management, you want to recognize shock, stop any bleeding if there is any, replace the volume if you need to, and restore perfusion to the tissues. The next thing to think about when we look at ABCD is disability, right? And that's where we go back to this Glasgow Coma Scale, see what their disability is, see if they have any sensory function issues, any motor function issues, figure out what other imaging you need to order from that standpoint. E is exposure environment. So you want to expose the patients. Whenever we have trauma patients come in, the first thing we do is we take them out of their clothes, put them in a gown, because if patient's not exposed, you can't really assess them for all their injuries, right? You want to make sure you keep them warm though, as you do that with blankets or sheets, because there's good data to show that keeping trauma patients warm helps with their outcomes. And then you also want to roll them, right? Make sure you don't miss any injuries on their back. You want to make sure there's no injuries in their axilla that you miss. And if they're in C-spine precautions, then make sure you hold those C-spine precautions we talked about while you roll the patient. You may also want to do things like check for rectal tone if you're worried about spinal trauma. And all of this can be kind of included in that secondary survey as you're going head to toe on the patient. Okay, so that being said, we've kind of gone through the approach to the trauma patient in the first 30 minutes, right? That's kind of the primary survey. Next, we're going to move on to the secondary survey, which is that head to toe physical exam. This is probably where you're going to ask about history, any allergies, medications, things like that they've had. The next thing to consider as part of your secondary exam is something called the FAST exam. So FAST stands for Focused Assessment with Sonography for Trauma. You typically do this in blunt trauma. And there's been really good data to show it decreases the time to operative care, resource utilization decreases, and the cost to blunt trauma patients also decreases. And it can be completed within 5 minutes once you're really trained on it. So what the FAST does is it actually evaluates 4 anatomical areas or potential spaces for the presence or absence of fluid. So there's 4 spaces kind of in the body where fluid will pool. You can say if there's any sort of fluid or blood in the belly. The first one is what we call Morrison's pouch or the hepatorenal recess. So it's on the right side between the liver and the kidney. The second is the splenorenal recess on the left side. The third is the rectovesical or retrouterine space by the bladder. And then the last is the pericardial space where you're trying to really make sure if they don't have any sort of pericardial effusion or tamponade. The assumption is that the fluid represents blood in the setting of trauma, right? But just keep in mind that there can be fluid there like ascites, urine, or bowel fluid, and you can't tell it apart on ultrasound. So really, this is kind of one of those things that you can tell if there's some sort of fluid. And most times in trauma, if the situation makes sense, you're assuming it's blood and the patient needs to go to the operating room, right? But it could be a lot of other things too. One of the things we tell our students is if you ever have patients who come in, non-traumatic patients who come in that are cirrhotics and have ascites, those are really good patients to practice a FAST exam on, because a lot of times because they have ascites in the belly, they will often have positive quote unquote FAST exams because that ascites is going to pull in those dependent spaces. Those are good patients to kind of practice your FAST exam on and see what a positive FAST could look like in the trauma patient. Their most dependent areas when the patient is supine. So typically when you're doing the FAST, the patient is laying flat on the bed if they're able to. And typically you need about 250 cc's to 600 cc's of fluid to accumulate to be able to actually see it on the FAST. This goes through the hepatorenal recess imaging, which is between the liver and the kidney on the right side. This looks at the splenorenal recess and where that's anatomically located on the left side. And then this box is where you're typically going to be looking for your sub-xi view. So this video is actually going to go through how to do the FAST, and what you'll see on the left-hand side, why I like this video, is on the left-hand side, there'll be the ultrasound imaging that you're actually going to see. And then on the right-hand side, you'll have the patient here. So you can actually see where to put the probe on the patient.
So now we're going to go over how to perform the FAST scan. And this is a scan that's used in trauma. It's called a focus assessment using sonography for trauma or in trauma. You're basically looking for free fluid in the abdomen, around the heart, in the chest, as well as looking for pneumothorax of the chest. So we're just going to go over the protocol that I used. So here we're going to use the phased array probe. The patient is going to be in a supine position because it's in a trauma setting, so they're usually lying flat. You're going to put the probe, you're going to assess the right upper quadrant, the left upper quadrant, the pelvis, and then you're going to assess the heart and then the lungs. And we'll go over through it in that order. So the first scan is the right upper quadrant scan. So here is the right upper quadrant scan. Indicators up towards the head. It's around the 8th to 10th intercostal space in the mid-axillary line. And you're looking for Morrison's pouch, the space between the liver and the kidney for free fluid. Make sure, in addition, you look towards the edge of the liver because sometimes fluid can track there also. The next scan you're going to do is the left upper quadrant scan. So this is knuckles to the bed, looking for fluid around the spleen. And here we see the spleen. And the fluid doesn't track between the spleen and the kidney usually unless there's rupture of the splenorenal ligament. In addition to looking at fluid around the spleen, you want to look above the diaphragm, looking for any fluid in the chest. And here you see a good mirror artifact sign. There's no fluid there. That's completely normal. And remember to also do this on the right upper quadrant, looking for fluid in the right chest. The next portion is going to be the pelvic scan. Here, you're looking for free fluid above the bladder. So indicator is up towards the head. And you see the bladder here. There's no free fluid above the bladder. Another organ to identify is the prostate in this view. And free fluid, once again, is above the prostate and above the bladder. The next view is going to be the cardiac view, looking for pericardial effusion. And there's two views you can use. You can use either the subxiphoid view. And since this is on the standard mode, the indicator is going to be towards the patient's right side. And you're going to identify the liver and sweep in and look for that heart. And here we see the heart, the 4 chambers of the heart. And when the patient takes a big breath in, brings it closer, you get a better view, that subxiphoid view, looking for pericardial effusion around the right ventricle or left ventricle, and looking for any collapse of these ventricles, signifying tamponade, specifically right ventricular diastolic collapse or right atrial systolic collapse. Another view you can use, if you can't get a good subxiphoid view, is a peristernal long axis view. And once again, since we're in standard mode, the indicator is going to be towards the patient's left hip. So here, you're getting a peristernal long axis view. And the main thing you're looking for is pericardial effusion. You're not assessing, you don't have to assess, necessarily assess all the heart function, but look for pericardial effusion and looking for tamponade here. And this looks normal here. You can see the pericardium both anteriorly and posteriorly in this view. And the last portion that you do is looking for pneumothorax, and that's looking for lung sliding. So once again, the indicator is going to be towards the patient's head, second intercostal space, mid-clavicular line, where you would do a needle-thoracostomy basically, and you would decrease your depth. So you see I'm decreasing my depth all the way down here. And here you're looking for lung sliding. So when the patient breathes in, so if you can take a big breath in, you see there's lung sliding on the screen there, and that indicates there's no pneumothorax. If there is no lung sliding, that is highly suggestive of pneumothorax in the setting of trauma. You want to make sure you do both the right side and the left side, looking for lung sliding. And this patient has lung sliding on both the left and right side.
Okay, and so at the end, you notice that they actually went through not only the FAST, but they also looked for lung sliding, which is something else that you can do when you're assessing trauma patients to make sure they don't have any injuries. The other thing I wanted to briefly mention was that generally speaking, the FAST is for blunt trauma, but there is one exception to that, and that's when you have penetrating trauma within the box, as we say, right here. And typically, if you have penetrating trauma within that box, you're doing a quick pericardial view to look at the heart to make sure there's no tamponade there. But you don't need to do the rest of the components. But you may see that being used for penetrating trauma that's to the chest in that area. But otherwise, we typically do it for blunt trauma. There are, just like with any other procedures or things you do, there are contraindications, right? That could be there. So ultrasound is a non-invasive modality that you can use. And the only time it's really contraindicated is if it would delay or negatively impact a clinically obvious need for emergent OR. So you already know the patient needs to go to the operating room before you even do the fast exam, and this would kind of slow that down. That's when you kind of really don't want to do this. And it shouldn't be performed or unsupervised, right? You really want to be able to do this with someone who's familiar with it and who's trained on it. And these are just going through some imaging to look at abnormal versus normal. So this is normal, right? Liver, kidney, you see lung here as well, and you don't see any black between these areas. So keep that in mind and then look at this. And here you can see free fluid right in here, right? This is kidney, this is liver, and this is your lung. And you see fluid here that wasn't there in this image. That's what we consider a positive fast, right? And same when we look on the other side, this is spleen, kidney, and lung is that bright white line, the tip of the lung. So right here, you don't see any black fluid. And again, this is a positive fast where you would see like right by the inferior tip of the spleen, you see some free fluid right here. And your kidneys down here. And your lung, it's a little tough to see, but it's that bright white right at the bottom. This is the bladder, no fluid here. And then here you can see a big pocket of free fluid. This is more of a dynamic image of free fluid in the abdomen. And again, you see kidney here, you see liver here, you can see a little bit of lung here, and you see that liver is just kind of floating in fluid right there. All right, so now we've gone through ABCs, we've talked about secondary survey, we've talked about FAST. The other thing I want to bring up briefly is the something we don't really consider when we talk about trauma patients, and that's breaking bad news. Because oftentimes when you have sick trauma patients who come in, they're going to have injuries that you're going to have to discuss with their family and loved ones. And I just wanted to put one slide in here on that, because I don't think we talk about this enough, and I don't think we train on it enough, even though it's something we do quite a bit in the emergency setting in terms of breaking bad news and having difficult conversations. So there's a lot of protocols out there in terms of how to break bad news. I would use the one that you think you're most comfortable with. I personally like spikes. It's one that's been studied before. The reference for the paper I got this from is right here on the bottom. But breaking bad news is difficult, but it's a necessary skill, especially in the emergency setting. And this one is a really great mnemonic that kind of helps you go through all of the different components when you're trying to figure out how to break bad news. The first one is the setting, right? Making sure that the patient is in a quiet area, they're sitting down, there's no interruptions when you're trying to talk with the family. P is the perception. Always ask the patient or family what they think is going on, right? You may think they think one thing, but they may be thinking something completely different. So that's a great way to kind of get everybody on the same page in terms of what they all think is going on. Then ask them how many details they want to know. Some patients and family don't want to know details. Some want to know everything. So knowing how much information they want is also important. And then explaining the facts, right? Without jargon, just provide the objective facts. That's the key. And then lastly, sometimes this can be really bad news. So addressing the patient's emotions, right? Making sure if you have a social worker or someone who can come in the US, we have someone called a chaplain who helps the patients, making sure that they have someone there who can help them with their emotional needs. And then summarizing the plan for the patient or the family as well. The next procedure I wanted to briefly talk about before we go into cases is chest tubes, because those are something that you might also do in the trauma setting. Chest tubes, typically you'll do them for pneumothoraces, you'll do them from hemothoraces. Those are kind of the most common indications on the trauma patient that you'll do them for. And so you want to make sure that they're done correctly, because there can actually be complications that can happen if they're not done correctly. So like I said, hemothorax, pneumothorax are probably the most common indications that we use in the trauma setting, but they can also be used for other etiologies on the medical side, like an empyema or a chylothorax or a pleural effusion. The anatomical placement is probably the most important thing, right? And that's because you want to avoid placing it directly over the area where this vascular bundle is, because you can cause injury, right? You have vein, artery, nerve that runs below every rib. And that's why we always say you want to place chest tubes above a rib, right? You also want to make sure that you're avoiding placement directly over an area of infected tissue, like a cellulitis or an abscess, because you're going to seed that infection as well. Place the patient on the monitor, make sure they have good large bore IVs. And this video is going to go through briefly how to place that chest tube.
I'm Dr. Jess Mason, and this is a method for chest tube placement. Before you get started, make sure your patient's pain is well controlled and secure their arm up behind their head with tape or restraint. I want to make sure this guy doesn't move. Once you're sterile, prep and drape a wide area to keep a large field visible throughout the entire procedure, from clavicle to costal margin, sternum to mid-axillary line. Then you're going to palpate down to the 4th to 5th wide area to keep a large field visible throughout the entire procedure, from clavicle to costal margin, sternum to mid-axillary line. Then you're going to palpate down to the 4th to 5th intercostal space in that anterior axillary line. That's the spot. Now let's go get our equipment set. Take the large Kelly clamp and clamp the tip of the tube. Some people alternatively will go through that distal hole. There's no right or wrong answer. Take the second Kelly clamp and clamp the other end of the tube to prevent fluids from gushing out. Now, let's anesthetize the skin. Make a wheel at the skin, and then you're going to aspirate as you insert the needle. You'll know when you get in the pleural space because you'll get a gush of air or fluid back in the syringe. Then you're going to inject liberally as you withdraw the needle. Give that a minute to take effect, and then you're going to make your skin incision. So take your 10 blade and make a nice long skin incision. And now we're going to bluntly dissect with our Kellys, the small Kellys. Remember, we're going one rib space up because there's a neurovascular bundle that sits at the inferior margin of every rib, and we want to avoid that. Hold the Kellys here so you don't accidentally insert them too far. And insert the Kellys. Now, if you're new at this, it takes more force than you might expect, and it really does feel like a pop. That was it. That's in. Spread the Kellys open to create a hole in the pleura and insert your finger. Withdraw the Kellys. Now, I want you to feel right now in this moment that you are in the pleural space. So feel the inside of the ribs, feel the lungs, feel for adhesions. That's in for sure. Now we can take our chest tube and we're going to insert it supero-posteriorly towards the apex. Guide it along your finger and insert it until the last hole is all the way in. Perfect. Now we're going to suture it in place. So get your O-silk, and remember, there's no proven superior method for suturing in a chest tube. Here's one method that I like. We're going to make a simple interrupted suture on one side, pull through so you have equal ends of suture on either side, and tie a surgeon's knot. This is your anchoring knot. Wrap the ends around the tube and tie. First, I use zero form. Next, I use gauze that I've pre-cut out. Now we're going to tape it in place. Now we're going to pinch the tape around the tube. Now we're going to connect our chest drain. Gracefully, cut the end off. Connect your tubing and remove the clamp. Get your x-ray and you're all done.
All right, and then chest tube post-procedure, you want to make sure you repeat the vital signs to include the pulse ox. You listen for bilateral lung sounds, right, to make sure the chest tube is actually functioning. Get a chest x-ray to verify the lungs re-expanded and that the placement of the chest tube is good. And then evaluate the pleural vac, right, to look for signs of air leak, to make, and also look if it's a hemothorax, that how much blood is coming out, right? Because if there's too much blood coming out, that patient probably needs to go to the operating room. There can be a lot of complications from the chest tube. They're all listed here. I'm not going to go over them for the sake of time. I really wanted to try to go through at least one case, and the rest of them we might have to save for next time. But this is kind of the first case. So you have a paramedic team that arrives with a 34-year-old trauma patient who was involved in a high-speed single car MVC. He was restrained, airbags deployed. He was the driver, and there was the other driver died on scene. There was no other passengers. EMS extricated the patient easily. They placed a line with an IV. They started running normal saline. They placed him on a non-rebreather mask, but he remains tachycardic, hypoxic, and altered, and GCS was consistently 14. What's next? So first, we're going to do primary survey, right? So you want to make sure that their airway is intact. When you do breathing, you see that they have decreased and coarse breath sounds. You check their peripheral pulses going on to circulation, and those look okay, and the vital signs are there. What are you kind of worried about? What do you want to do next? So next you want to move on to your secondary survey, right? So you look and you see that the patient is tachycardic, tachypnic, hypoxic. When you look at their CNS, they're awake alert, they're confused, they don't really remember what happened. Pupils are equal round reactive to light, they're moving all their extremities, complaining of chest pain. Head, neck is unremarkable. Cardiovascular, they're tachycardic. Respirations, they have decreased breath sounds on the right side. They have some crepitus. The belly is soft, right? No long bone or pelvis deformities that you see, and you see some bruising on the right side. You get their medical history, which is as above. They're unemployed. They don't have any family history. And then I've summarized the review systems there as well. So as far as next workup goes, you probably want to do a fast and a chest x-ray, right? Especially given that the patient has had decreased breath sounds and bruising on the chest. So you want to do a quick fast, which looks like it's negative, and then you do an x-ray and you see this. So you typically want to put in a chest tube, right? And then honestly, we typically get a CT of the chest once the patient is stable to make sure we assess for any sort of other injuries in that area. The last thing I wanted to really bring up was this was a single vehicle accident. And so is there, apart from the traumatic workup, is there anything else that you need to work up in a single vehicle accident? And this is actually really important. This was on my boards. For single vehicle accidents, you want to think about the S's of single vehicle accidents. So syncope, meaning you want to work them up for syncope. Did they faint? And that's why they got in a single vehicle accident, right? You want to think about seizures. If they seized, then that's why they got in an accident. Strokes, any sort of substances or ingestions, if they were drinking or doing drugs. And then the last thing is suicidal ideation. Was this person trying to kill themselves, right? And that's why they got into a single vehicle accident. And so these are some things that you think about apart from the trauma evaluation of the patient, right? And so you can do an expanded workup to look for those things. You're doing blood counts, you're looking at their electrolytes, you might do EKG and troponin, a dimer if you think they're high risk for PE, because that can be one of the presenting symptoms of syncope. And then a psych consult if you screen them and you're worried that they actually wound up having a suicidal ideation as the cause of why they got into the accident in the first place. So as your case evolves, you see that the CT scan shows no further injuries. The lab work is unremarkable. The patient actually gets admitted to the hospital for chest tube management, and he's seen by a psychiatrist during that time, and he's noted to have depression and suicidal ideation. He admits that he was trying to kill himself, and that's why he ran his car into the pole. And once the chest tube is removed and the patient is medically cleared, he's actually transferred to a behavioral health facility to further manage his depression. I know it's 10:55, so we probably, this is probably a good place to stop for now, and then we can go through the other cases at a later time. The thing I wanted to end the lecture with is that there's a lot of ways to kind of get involved if this is something you're interested in. There is a Pakistani Society of Emergency Medicine. ASAP, which is our national EM organization, has an international emergency medicine section as well. As well as the Society of Academic EM. So I wanted to put some of those opportunities up there because all of these different organizations actually have trauma and injury prevention sections or disaster medicine sections to get involved with if you feel like this is an area that you're interested in doing more work in. Going through our summary really quick. So we went through ATLS basics, right? We went through airway, breathing, circulation, disability exposure. We talked a little bit about airway management and different adjuncts to airway management, as well as definitive airway management. We talked a little bit about the FAST exam and breaking bad news. We reviewed procedures such as chest tubes, and we went through one of the trauma cases. These are all of my sources. And then this QR code has an evaluation link, if you guys don't mind filling that out. And hopefully we can set up a time to kind of finish this lecture with the rest of the trauma scenarios soon. Thank you guys, and I'll take any questions as well.
Hi, Assalamualaikum, Dr. Sara. I am Ahmed Bajwa, the president of IFMSA local chapter in Shifa College of Medicine. Thank you so much, first of all, for the amazing session that we had. It was very informative, and unfortunately, we couldn't have this session physically when you were in Islamabad, but we're still glad that we could make it. I have a very short question. A lot of people actually reached out to me and they want me to put it out to you. As you mentioned in second last slide, that people who are interested in emergency medicine, students especially who are currently studying, what pathways they can choose. Like, for example, a lot of people want to go to a residency program in US, including me, in emergency medicine. And a small short guide if you could provide to everyone, a general. So that would be very kind of you.
Yeah, so I think for emergency medicine, one of the biggest things for us is actually getting exposure into kind of the clinical arenas in America. And so getting rotations in America, it's going to vary a lot by the medical school. What I've noticed, at least from what I've seen, is that there are certain medical schools, every medical school does it differently. And so like I know the med school that I work at, they have a process for IMGs to apply to get rotations within any rotation in our as part of our med school and in our hospital. So most places do it like that. So that's one way to gain, I think, clinical exposure. The other thing you could do is if you have a summer or something that's free and you want to do research, that's a lot easier to do, where you can kind of blanket email a lot of different programs and be like, hey, I'm interested in doing research. What are next steps to do that? And while you're there doing research, certain institutions will allow you to shadow. It varies from institution to institution, but certain institutions will actually allow you to shadow. And I think I saw a question about like what you would say for a first year med student who's interested in EM. I think just expanding your exposure to emergency medicine, whether that is in the clinical arena or whether that's through some of those organized sections, right, that we have within the right here within the different organizations. These can actually serve as a really good resource too, as far as finding out which programs are a little bit more IMG friendly, and that will take rotators for international sections. So that's another thing to consider when you work with these. For example, I know like SAEM, this is one of the more academic organizations within emergency medicine, so they would be a good one to kind of talk to about that stuff.
Thank you so much, Dr. Sara, and anyone else who has a question can ask now.
Yeah, thank you for having me. And again, I'm so sorry it didn't work out in person. I actually got really sick when I was in Pakistan. I had to delay my flight back, and I got sick the day of the lecture. So I really appreciate you guys letting me come back and do this virtually.
Thank you so much, ma'am, for joining us and giving us an opportunity to learn from you. Thank you so much, ma'am.
No problem. My pleasure. Have a good rest of the evening, and hopefully I'll see you guys again soon.
Inshallah. Thank you so much, ma'am.
All right, inshallah. Take care. Khuda Hafiz.
Thank you so much, everyone, for joining us.